Hello everyone, we are now going to go over the peripheral blood flow cytometry plots from a 15-year-old boy who presented with leukocytosis and 60% circulating blast. Let's start with CD45 versus site scatter. We see a small population in the lymphocyte gate, which is defined by bright CD45 and low site scatter. The majority of our cells are seen here in this blast gate, which is defined by low site scatter and dim CD45 expression. And let's follow through these dark blue population, which are sitting in the blast gate. These are negative for CD19 and CD20. We see our background B cells that are positive for both CD19 and CD20. These cells are negative for CD5, and our background T cells are positive for CD5. And they have CD38 expression. They are negative for CD10. They're negative for kappa and lambda expression. And we see our B cells in the background that express kappa and lambda. In the next tube, these cells are painted in maroon, and these cells are positive for CD38 and CD34. They have partial HLA-DR expression, and they are positive for CD117. They are almost negative for CD33. They are partially positive for CD13. They're negative for CD64. They're negative for CD14. And here are the monocytes, which are painted orange, that are positive for both CD14 and 64. These are negative for CD11B. Again, monocytes are positive for CD11B, and also some of the maturing granulocytes and neutrophils are positive for CD11B. Our blasts are negative for CD8. So far, we see that a blast population that is positive for CD34, CD38, CD117, which is a myeloid marker, and partial CD13, which is also a myeloid marker. And it is negative for the B cell markers 19 and 20. It is negative for CD10, which is commonly seen in B lymphoblasts. It is positive for there is partial expression of HLA-DR, and it is negative for CD8. It is negative for monocytic markers. So far, it is expressing myeloid markers. When we go to the next tube, which is a T cell tube, we see that these blasts express, which are painted in blue here, they express CD7. They're negative for CD1A and surface CD3. They're negative for CD5. They're positive for CD99. CD99 is an immaturity marker. They're negative for CD56, and they are positive for cytoplasmic CD3. So we can usually compare the T cells in the background to decide whether cytoplasmic CD3 is positive or negative in a population. If we see in this population, it is reaching the intensity of the background T cells, so this is positive. So far, we have both T lymphocyte markers, cytoplasmic CD3 and CD7 that are positive. And there are some myeloid associated markers like CD117 and CD13 that are positive. CD117 and CD13 are not specific for myeloid, although if everything else is absent, that is all lymphoid markers and monocytic markers are absent, when CD117 is positive, we can just call it myeloid leukemia. But here, when we have a situation where there is cytoplasmic CD3, which is a lineage specific marker for T cell lineage, is positive, then we cannot use just 117 to call something as myeloid. So here we definitely have a T lymphoblastic population. The question is it just T lymphoblastic cells that are expressing some myeloid markers as we see in early T precursor leukemias, or is it a mixed phenotype leukemia? So to decide that, an additional tube was performed along with MPO. So we see our CD34 and TDT positive population here. Those are the immature cells, are the blasts, and those and then we have MPO. We see that those blasts are negative for MPO, which can be seen against the normal background granulocytes, which have the bright MPOs here. Our blasts do not reach the intensity of the MPO positivity here. If you see 117, almost all of the blasts express 117, but MPO is typically negative here. So this is a T cell lymphoid blast population that is expressing CD117 and CD13. So This is often seen in ETP-ALL. ETP-ALL or early T precursor ALL arise from early T precursors or those cells that have not committed themselves to T cell lineage yet. Therefore, they express some myeloid markers along with T cell lineage markers. The T lineage markers that will be positive are CD7 and of course the lineage defining markers cytoplasmic CD3. But CD8 and CD1A will be negative. So you can see that in our case too, that CD1A and CD8 are negative. And CD5 is also usually negative. Here in our case also we see that CD5 is negative. But even if it is positive, it should be positive in less than 75% of the blasts. If it is more than 75% blast, positive on more than 75% blast, a term near ETP-ALL can be used. Kind of, it just means that it just progressed a stage more than ETP-ALL. Because if you remember in your T cell maturation, CD7 is the earliest marker, and then CD5 and others are acquired much later. And so the main differential diagnosis is with mixed phenotypic acute leukemia, for which we need MPO, and MPO should be negative in ETP-ALL, and if it is positive, it is more consistent with a mixed phenotypic acute leukemia T myeloid type. Now, why is it important to identify ETP-ALLs? Because one, prognosis-wise, initially they were thought to be like more associated with poor prognosis than typical classic TALL, but there is also studies with a larger population that said that there is really not much difference prognostically, but it's not conclusive yet. What is the reality? It is still under study. The other thing is, when these patients relapse, there is a chance that they can relapse either as TALL or as just myeloid leukemia. So that is why it is important that you document this in the flow report and keep an eye on all these markers during follow-up. Thank you.